Welcome to podcast 7.
I'm Fran.
And I'm Minnie.
And as always, please do feed back to us. The scoring system where you tick the stars is incredibly helpful, and it's also anonymous, so you can be very honest with your feedback on there. And we'd really like every one of you who listens to these podcasts to score us, please, because it's incredibly helpful for us to improve them and to get an idea of what you're finding helpful.
I absolutely agree with you there, Fran. So this podcast tip is to always check the pulse in older patients. So that's patients over the age of 60, as atrial fibrillation is often an incidental finding, so a finding that we find unexpectedly.
Yes, and obviously our topic, therefore, is atrial fibrillation. Thanks, Minnie.
Okay, so we're going to start with a little scenario of a patient and then talk you through atrial fibrillation and treatments, etc. So we're going to start with Mabel, who's a 78-year-old lady, and she's come to the clinic with symptoms of a racing heart, shortness of breath, dizzy spells and occasional chest pains. When you examine her, you find she has a pulse of about 120, but it's irregularly irregular. She has a respiratory rate of 24, blood pressure of 110/60. She's not pale, she has no goiter when you feel her neck, her heart sounds are normal, chest clear, and when you check her ankles, there's no signs of swelling. At this point, you've sent her for an ECG, although you can diagnose atrial fibrillation clinically, and you find that her rhythm is irregularly irregular, and there are no obvious P waves on the ECG. So she has a diagnosis of atrial fibrillation. Fran?
Yeah, so that's just to reiterate, those are the things that you're looking for in ECGs, and maybe we can add some ECGs to the form which show these to you so it becomes more obvious. So what is atrial fibrillation? So this is an arrhythmia or an irregular heartbeat, and it results from the irregular and disorganized electrical activity in the atria, and these rapidly firing impulses cause disorganized depolarization and then sort of disorganized and ineffective atrial contractions. And because the atrioventricular node is getting more impulses than it can conduct, it ends up producing an irregular ventricular rhythm or pulse rate. And often this pulse rate ranges between 160 to 180 beats per minute, although typically it is slower in older people. Okay. Quite often we classify it according to how the episodes are. So there's paroxysmal AF, which is when people have episodes when they're in this heart rhythm, this atrial fibrillation, but then it reverts back to normal, to what we call sinus rhythm. And contrary to that is persistent atrial fibrillation, which is when it lasts for more than 7 days, and it's therefore unlikely to switch back into a normal rhythm after this time. I don't have any figures for Zambia, but the prevalence of atrial fibrillation is 1.6% in the whole of England.
That's an interestingly high statistic, actually. I did hear the other day when I was listening to another podcast, a heart podcast, they were saying that if you took everyone over 40 in the United Kingdom, 1 in 4 of those people would develop atrial fibrillation at some time in their life.
Well, it's sure enough then, getting there.
Yeah.
Oh dear. Right. So,
okay, so Fran,
Sorry, Minnie.
I was just going to ask you the very same question. What's the most common cause of atrial fibrillation then, if it's so common?
Okay, so the most common causes are cardiovascular disease. So typically in the UK, that's ischemic heart disease, hypertension. Less commonly now in the UK, but I would imagine more so in Zambia, is valvular heart disease, something like rheumatic heart disease. So that's the most common thing. But then you've got other non-cardiac things that are common. So, for example, drugs such as taking thyroxine or a bronchodilator like salbutamol. acute infection. So this is something that I see a lot with my patients, that they maybe have a community-acquired pneumonia, and that flips them into atrial fibrillation while they're unwell. And quite often, actually, they then flip back again into sinus rhythm on recovery. Electrolyte imbalances, things like high potassium, lung cancer, pulmonary embolisms, and overactive, so hyperthyroidism, and diabetes apparently as well.
I'd just like to ask you, Fran, actually, with your patients that flip into atrial fibrillation with an infection, and then when they're better, they're back in normal rhythm. What do you tend to do in that case? When you're talking about the paroxysmal AF, that you would treat it the same?
Yeah, so I think with them, particularly if they've been symptomatic with it, so they've had a racing heartbeat or they've been dizzy, then it's quite easy to watch out for them going into it again. And I would normally get them to monitor it and see whether it's a pattern that's recurring or if this was just a one-off occasion triggered by a pneumonia. And if it's a one-off occasion, then I wouldn't treat. But if it's something that recurs, well then, so interestingly, advice has changed. So it used to be thought that paroxysmal AF was had less risk associated with it, but actually that's no longer thought to be the case. So actually, with someone who's going in and out of atrial fibrillation, we now treat them exactly the same as we would with someone who's in persistent AF.
Okay.
Yeah. So moving on, so other factors, dietary and lifestyle factors. I mean, this comes into everything, doesn't it? Yeah. What they mentioned there was excessive caffeine intake, although as a coffee drinker, I'm quite pleased to hear that 3 cups of coffee a day actually are quite beneficial for my heart, particularly, not just for my heart, but for my general health, and particularly in women for their cognition. But I think for people who are particularly sensitive, and also people who are very sensitive to alcohol, having increased alcohol intake. And then obesity as well, which is obviously a risk factor for an awful lot of things.
Yeah, absolutely.
And then finally, they say lone AF, where there's no obvious cause and all investigations are normal. And apparently this is up to 11% of people with AF. But, without, off the top of my head, thinking of my patients, of whom I have a lot with atrial fibrillation, I don't think I have a single one that has no obvious cause for it. I think there's pretty much always been a cause.
Yeah, okay. So if we go back to our patient Mabel, we obviously want to find out why she's got into AF. And she tells us she was diagnosed with a heart attack, myocardial infarction several years ago, but is currently on no medication.
Okay, so that's obviously her cause for that.
Yeah.
So why do we worry about it? So the main risk with being in atrial fibrillation is that of a stroke. So what happens is with because of this disorganization of the atria and the sort of the fibrillating of the atria, the blood is much more static and it can form small clots, and these then break off and cause stroke and thromboembolism. And so what was interesting, I read that you have a 5 times greater risk of stroke and thromboembolism if you're in atrial fibrillation than people who are not. It does obviously depend on the presence of other stroke risk factors. But what's interesting, and I didn't know this, was that the stroke severity is greater when the stroke is associated with atrial fibrillation than with other causes. Yeah, so that's quite useful.
Yeah, just definitely makes you want to sort it out, doesn't it?
Absolutely, yeah, get on and treat it, yeah.
So talking of strokes, Mabel, back to our patient Mabel, she tells us that last week her face dropped on one side and her speech was slurred, and it lasted for about 30 minutes and then returned completely to normal. And examining her neurologically today, we find that everything's normal. So this was likely to have been a transient ischemic attack, or a TIA, which has probably come from her AF, as you've just described. So a TIA is an episode which resolves completely within 24 hours and is often known as a mini stroke. Certainly in the UK, Absolutely. People call it that.
Yeah. So obviously, so then we go worry about her. So other things we would worry about with risk is heart failure. So this is when the heart is not pumping so well. So because of this disorganization of the atria, it means that the blood flow into the ventricles is ineffective, and the cardiac output can be reduced as much as 10 to 20%. And so when this is compromised, it just means the ventricles aren't pushing the fluid around so well, and then pushes the patient into heart failure. Yeah.
So luckily for us, our patient Mabel has shortness of breath, but has no evidence of pulmonary edema when you've examined her, and or left ventricular failure, and she's got no sacral or ankle edema. So that was good for her for this time, but you'd have to keep watching out for it.
Yeah, absolutely, and quite often that's something that people present with when they're in AF, because they've gone into rapid heartbeat and then go into heart failure. That's quite often a presentation. And then finally, just to say in terms of risks, interestingly, it actually is shown to reduce the quality of life. So atrial fibrillation can result in reduced exercise tolerance because obviously your heart's not beating so well, but also interestingly impaired cognitive function.
Yes.
And the statistic here is that people with AF are twice as likely to die prematurely than people in sinus rhythm. So
that is interesting, especially as we...
Interesting but depressing statistic, yeah.
Yes, one perhaps not to be shared.
Yeah, certainly I haven't been mentioning that to my patients, yeah.
So what do we do next? We want to, if we go back to how we're going to diagnose what's going on when someone comes in with a presentation of palpitations.
Well, so as you said in the tip, actually, it's about checking the pulse rate, and if you feel an irregular one, so that means that there is no pattern to the beat at all. And actually, we've been taught that the best way to do this is using a stethoscope and checking the rhythm at the heart, and not the rhythm and the rate at the heart, and not at the radial pulses. This is more accurate. In an ideal setting, you would do an ECG as well to confirm that.
And how do we go on to treat a patient like Mabel?
So Mabel is actually relatively stable. She hasn't gone into heart failure. Her heart rate isn't too quick. So at the moment, we wouldn't need to admit her. We'd want to think about all the causes that we discussed earlier, and then identify and manage any of those. So if tests are available, you might want to exclude some of the reversible causes, such as electrolyte imbalances, by checking her kidney blood test. If possible, you would check her thyroid, her glucose, and a full blood count. And if she had any chest signs, you might want to do a chest X-ray to rule out a pneumonia or even a lung cancer that you hadn't necessarily considered.
Okay. So for Mabel, we know that she's got an underlying ischemic heart disease, so we probably wouldn't need to do any other tests at this stage unless it was clinically indicated.
Absolutely, yeah, I think that's absolutely the case, and certainly I wouldn't be over-investigating my patients. And so the mainstay of treatment isn't actually to put them back into a normal rhythm. It's about controlling the rate, and the evidence is that if you can control the rate, then the cardiac output is good enough to maintain a normal life and to keep this person fit and well. So normally we use rate controlling treatments. So typically these are beta blockers, such as atenolol, which I know is on the formulary in Zambia, or a rate-limiting calcium channel blocker. So not all calcium channel blockers are the same. So something like verapamil would be what you would use for Mabel. The choice would depend on also if they had other things going on. So if, for example, if Mabel has some asthma, you absolutely would not be using a beta blocker because that is completely contraindicated. Conversely, if we thought that she had some heart failure, then verapamil would be contraindicated. So you'd be looking at the patient and then deciding which one you would do. Very occasionally, having said about we don't try and revert people to sinus rhythm, very occasionally, if it's one of these lone people who seems to have no cause for their heart being in atrial fibrillation, we do occasionally cardiovert them, which is effectively defibrillating someone with a defibrillator. It looks pretty brutal
Yes.
to try and get them back into sinus rhythm. I have to say, I have had patients who've had it done and never successfully for any length of time, unfortunately.
Okay.
Yeah. So going on in the UK, obviously we have access to different medicines and different monitoring. So what we currently use is something called a CHA2 DS2 VASC assessment tool. And what I'll do, it does sound really impressive. Basically, they keep renaming them every time they update them. But what it does is it works out the risk for Mabel or whoever your patient is of her having a stroke and whether she needs to be on a blood thinning agent. So in
it's
the
quite
UK,
a useful tool, really.
Oh, it's incredibly useful. And what I could do is just put it up on the forum so you can have a look at it, guys, because I appreciate you won't be starting warfarin, but actually learning about these things is always interesting. So obviously you need to talk about the risks and benefits of anticoagulation, but the advice in the UK is that warfarin, or what we call a DOAC, which is one of these newer drugs such as apixaban, is superior to aspirin. And in fact, in the UK, we don't use aspirin anymore to prevent strokes in people with AF. Yeah.
Yeah, there's been quite a lot of research come out recently, hasn't there?
Yeah.
Okay, so for Mabel, we will start her on a beta blocker and aspirin and a statin because she's had a stroke.
Yeah, so obviously in Zambia, I think I think an aspirin is going to be better than nothing. But obviously, if you do have a DOAC, if you're working somewhere where you have access to that, that would be an awful lot better. Yeah.
And then she obviously needs following up, providing she remains stable at home, and reassess her and carry on from there.
Yeah, so I would normally see someone at their first diagnosis. I'd see them quite soon after. I think not just to check how they are clinically, but I think it's quite a lot of information for people to take on board, to understand and to sort of re-educate them about what they would need to do. And then obviously with the beta blocker, you'd be wanting to keep an eye on her pulse rate and her blood pressure. Yeah.
Excellent. Well, thank you for listening, and I would just like to apologise slightly for the quality of this particular recording, as we're having a few issues with the internet at the moment. But again, as we said at the beginning, please feedback to us with suggestions of what you'd like to hear or what you wouldn't like to hear.
Lovely. Thank you very much for listening. That's goodbye from me.
And from me. Goodbye.
Bye.